All right, we are live action, y'all. We are live action. Dr. Andre Pinesett here, the pre-med project expert, and today we're talking about health insurance and healthcare economics. It's a big topic right now because we got insurance companies on one side, and if you guys didn't know, right, they're trying to cap physician payments, and all the while, right, America's U.S. healthcare system is amongst the worst in the world, despite the rising cost of healthcare. And so tonight we're going to talk a little bit about reimbursement. It's going to be a short session tonight, but I want to make sure that we talk about in the economics of this, specifically the mechanics of how physicians get paid and what controls the flow of dollars and why physicians are so frustrated by the reimbursement process, so frustrated by the payments process. And for you guys as future physicians, it's super important to understand these economics because the reason we're in this situation is because for so long, physicians ignored the economics of it. Like, I just want to treat patients, but in the end, it leaves them in a position where they can't treat the patients they want to treat. So we're at the intro. We'll get right into it, y'all.
Today is the day, guys. You're going to take your future into your own hands. You're going to dominate. You're going to be successful. No excuses, just dominate.
All right, guys. Thank you so much for joining me. We are live action here. And so we're talking healthcare economics, right? How does it work? How does it work? How does it work? And there's been a lot of back and forth about whether insurance companies are right, whether physicians are right. Is it a combination? And I think to really get into the healthcare economics, we have to understand how all this stuff came to be about. And as so often happens in life, I hear this a lot when I work with students, where something goes terribly, terribly wrong, and they said, okay, yes, but that wasn't my intention. And I think that's kind of the issue in healthcare is that there's a lot of initiatives, a lot of systems, a lot of things that take place in healthcare with the best of intentions, but in the end, the outcome isn't what we intended, and now we're stuck with it. And so when it comes to our healthcare system and the economics of healthcare, it is all driven by the fact that we have a system of healthcare that's predicated on health insurance. That is the big crux of it. And so our healthcare system is built on health insurance, on an antiquated system, and we can't shake it loose. And as a result, it doesn't fit our modern day needs. And we're left with a very lopsided, backward system that really doesn't serve anybody. And I know on last session, I really bashed the insurance companies, but I can't really fault the insurance companies because they're doing the best they can as for-profit companies in the environment they were given. But at the same time, it's like, we got to find something that works. And it is the health insurance companies that are lobbying to keep the system in place because it keeps them in business, it keeps them making money, when we could really make wide-scale changes. And I think this goes for a lot of people. For when you're getting into medicine, you ignore the economics, you ignore the politics, and you're just like, I just want to treat patients. And it's a bad mentality to have because the politics and the money is going to drive how you're able to practice. And for me, I recognized early on the significance of the economics of healthcare. I recognized the significance of the politics of healthcare, the significance of the administration of healthcare, and recognizing that doctors were not in charge. And so for me, the way I look at healthcare, and this is the simplest I can put it, if healthcare was a McDonald's, where would the physician work in that McDonald's? Who do you think the physician is? Of all the employees at McDonald's, who is the physician in the cog that makes McDonald's work? Are they the CEO? Are they the shot in insurance? And who are you to talk about these things? And I think it's super important to understand who I am and recognize that when I talk about stuff, guys, I'm only talking about it because I know what the truth is. I know what the facts are, and I want to share them with you because I want you guys to have that same truth, right? I'm a truth bringer to you guys. And so for me, as an undergrad, I have a minor in business management, so I understand business. On the continuation of that, right, I went on and got my master's in public health with a focus in health service administration, health services management. So in running a hospital, I worked for multiple years in consulting, doing healthcare consulting, negotiating contracts, doing billing, all these things, working with the California Office of Statewide Health Planning and Development, working with the healthcare leaders, working with OSHA, our hospital accreditation board, doing all these things. So I've seen the backside of it. Then you fast forward, right? I am a physician, I am an anesthesiologist, but I'm not just any old anesthesiologist. I am a practice owner. So I own an anesthesia group. And yes, Daniel, we are live action, but I own an anesthesia group. And so therefore, because I own an anesthesia group, I understand what it takes to make a profitable group. I understand what billing is because I bill every single week. And I was actually going to pull up a whole billing sheet right here, but I was like, that might be a stone too far. Insurance companies might get mad at me. but we're going to break down what happens in this billing process so you guys understand this, okay? So from all angles, guys, I am expert in this stuff. I understand the mechanics of this, and so it's important that we, right, all see it together. So Spencer says, how do you see billing insurance differs between doctors and mid-levels? I'm becoming more interested in psychiatry, but I'm worried about sustainability. And the big question of mid-level providers, if you guys don't know what a mid-level provider is, in healthcare, and this is actually, I think it's a good jump off. Can we start here? Okay. So in healthcare, I talked about how we have an antiquated system. So we are so heavily reliant on insurance because at the time that we were developing our now modern healthcare system, we were looking at healthcare and accessing healthcare as you only went to the doctor when you were very sick, right? For my older people, when you grew up, right? If you sick, right, you just rub some Robitussin on it. My dad was peroxide everything. Oh, put peroxide on it, be all right. Oh, put the peroxide on it. Oh, you know what? Just drink a lot of water, drink some orange juice. I used to drink orange juice with garlic in it. That'll get rid of it, right? You don't go to the doctor unless you're critically ill. And this is the way our healthcare system was back in like the mid 1900s, 1940s, 1950s. And so it was like you only went to the doctor if something was catastrophically wrong, if you lost the arm, like that kind of thing. And so our exposure to healthcare and our understanding of healthcare was, ooh, we need to have some mechanism to when we have a catastrophic issue and we need massive insurance coverage that we aren't bankrupted in a moment for that coverage. And so like, what should we do? Well, how about insurance? If we had insurance for healthcare, when we had a major health event, this insurance company could step up and shoulder and protect us from this catastrophic loss. Similar to how health insurance or for how insurance works for cars, right? Every one of you guys has insurance for your cars. Why? In case you get in a fat accident and the car is lost, or you hurt someone or whatever, it's protecting you in extreme catastrophic circumstances. The problem is our healthcare system has morphed and that so many people aren't just having one catastrophic event and then dying. People have catastrophic events that they didn't used to survive when we created the system, but now they're surviving. So people can have multiple heart attacks and survive. People can have multiple strokes and survive. People can get in crazy accidents and survive because our healthcare is so good now. We got such great technology, all kind of things. But the problem with that then is now you have a lot of people that live through things they otherwise wouldn't have lived with and need chronic, expensive care. Yes, yes. We have more pharmaceutical interventions. We have more practical, physical interventions now than we ever have. And so people who just used to live a certain way, like, oh man, my back goes out every once in a while, I just live through it, now recognize, oh, I can go get physical therapy for my back. Oh, I can go get a surgery for my back. And so we have heavier chronic utilization of healthcare services. And therefore, what ends up happening, whereas accessing healthcare was a singular event, has now become a sustained, prolonged, recurrent, expensive event where you need therapies and modalities to manage all these chronic conditions. And the problem with that is that we're based on insurance, and insurance is designed to be catastrophic coverage, yet we're using it for everyday treatment in a chronic environment. And so because it's not designed that way, it can't function effectively. Does that make sense? The parallel, as I mentioned, is car insurance. Imagine if you used car insurance the way you used health insurance, where every single time you had to put any dollars into your car, gas, oil change, tire breakdown, whatever it happens, what if you didn't just pay for it out of pocket, you had to use your insurance? What would happen, right? When you guys have ever made a car insurance claim, what happens to your insurance premium? It immediately goes up, right, to cover those costs, those losses, because insurance companies don't expect to pay out. But now in healthcare, insurance companies have to pay out all the time and for a long time. And so because of that, they continue to raise the cost of healthcare. And to prevent more losses, they continue to deny and cap and limit and slow the flow of utilization of health insurance. Does that make sense? If that makes sense to you right now, like the video, let me know you're here. Comment, let me know. We are live action. Dr. Pinesett here. We're talking about health insurance. And we have to understand that, again, the best intentions were like, oh, we want to be covered. Ooh, if I have a heart attack, I want that to be covered and my family not to go bankrupt, blah, blah, blah. But now I'm surviving the heart attack and I need long-term care. I need to be on all these medications. I need all these therapies. They have cardiac. Did you guys know this? They have cardiac rehabilitation therapy. So you have a heart attack. We don't just send you out, whatever. We put you with a person who trains up and strengthens your heart like you would strengthening your knee. And so we have this system that was designed to have catastrophic coverage, and now we use insurance all the time. And so what it has made insurance become is it's not just coverage, it's actually like a discount service. So you subscribe to insurance So that way, all of the care you get chronically is cheaper than it would be otherwise. And so, because insurance companies know you're going to use the insurance that way, they have to charge more to cover everybody. Yes, yes? Okay, so now that's the important setup here. And so, I'm going to get to Spencer's question right here. So, insurance companies had never, the way our system was set up, was never intended to be used chronically and all the time by people. But now people want access, they want it now, they want to fix all these things, they want services, and they want expensive services. So insurance companies are like, listen, we'll go broke because these people, man, they're using it all up. So we started to do what's called a managed care model, where the insurance companies start to say, listen, we're going to manage the flow of care and we're going to slow people's utilization down. That way we can ration the funds and ration the care so as to avoid tons of usage and us all going out of business. Yes? And we're going to get to Medicaid in a second, William. I'll break it down for you. Does that make sense to everybody? Insurance was like, whoa, healthcare spending will get out of control if we don't limit some things. Let's cap some things. Let's push some things back. Let's set up a pecking order of how things have to go to slow the utilization of care, to keep costs contained, to keep our healthcare system sustainable. And so it became a system where we're trying to gatekeep and ration healthcare services to make the system sustainable. It's crazy. Okay? So that's what happens. Now, in the attempt, right? Because now we're trying to control utilization and control costs in healthcare. So in order to do this, what do you have to do? You have to gatekeep. Who are the gatekeepers? They're administrators. And so what you see is a rise in the amount of money put towards administrative costs in healthcare. This accounts on the insurance side and on the provider side for 15% of the overall costs spent in healthcare. And if you guys don't know the economics of it, we spend $4 trillion a year on healthcare in America. That is more than the Department of Defense's budget. It is more than so many things. It is $4 trillion in healthcare, guys. It's humongous. Humongous. $4 trillion. Of that $4 trillion, 15% is administrative costs. Right off the top. So approximately, right, almost a quarter goes to administrative costs. Out of every dollar spent, about a quarter goes to administrative costs. Then, out of that other 85%, it's split roughly a third, where a third of the other expenditures go to pharmaceuticals, what we call it drugs and devices, D&D. Drugs and devices. So pharmaceuticals, and then the fancy devices we like to use to do surgeries, to do home devices, all that kind of stuff. So drugs and devices, but the bulk of it is drugs. Then we have hospitals is another third, and then we have healthcare workers, which is the other third. And the reason I'm laying this out, because we're going to get to Spencer's question, this is the crux of it, is that when you have healthcare expenditures, you have 100% of the healthcare pie. You're trying to contain the costs and the utilization of this service. You look at, in business, you're looking at what are elastic and what are inelastic factors. So what are things that we can control the cost of? Are you following me here? So as we want to control costs and we want to gatekeep, administrative costs are necessary. Not only necessary, we must continue to increase them so that way we can better have a handle on care. And so insurance companies increase the size of their administrative departments. Healthcare, right? Like, oh man, we gotta figure out what's going on here. We gotta regulate. They increase their administrative size. We got more managers, we got more CEOs, got more, all these things goes up, okay? Because we need that. So 15%. The drugs and devices are what they are, and they're only getting more expensive. So we can't limit that. That's actually increasing, taking more of the pie. Hospitals are bigger and fancier, right? And they have more utilization. More people are accessing them. More people are going and getting surgeries and all these things. So that cost is rising. So then where can you cut costs in healthcare, guys? Come on, the other third, which is the healthcare workers. And so you try to decrease what we're spending on healthcare workers. And as a result, this is what happens. The expensive healthcare worker, the predominant one, right? The highest paid are the physicians. And so if you look at every other field, increasing salaries. Physician salaries, as adjusted for cost of living and for inflation, have either, across all specialties, has either stayed near stagnant, maybe a little increase, near stagnant, or has actually fallen. So you have physicians, if they would have been in this specialty 20 years ago, they're making bucks, who are now making less despite everything being so much more expensive. The glory days of physiciandom from You talk about the mid 1900s into the late 1900s, 1980, 1990, physician salaries through the roof. Physicians bring so much money. But then we had a shift and a cap on that. And so now physician salaries don't increase. Physicians aren't in control of what they're making anymore, and they're very capped on what they make. And so you see these capped costs. Yes? So now Spencer asked the question about mid-level providers. So we have seen the proliferation of mid-level providers. We're talking about physician's assistants, nurse practitioners, other advanced practice nurses. In anesthesia, we have CRNAs, right? A whole spectrum of mid-level providers. You have all these mid-level providers, and you're like, wait a minute, how do they fit in with what we're doing, right? In the field of psychiatry, you have psychologists, you have certain therapists, you have counselors, you have all these support services. These are like mid-level providers that are coming into fields where predominantly you would see a physician, now you see a mid-level provider. Why does that happen, guys? Because if we're trying to control the cost of healthcare workers, that third, the way to do it is to reduce the amount of physicians you're paying for and increase the number of other providers that are more affordable that you pay for. And so you see this all the time. How many times do you guys make an appointment with an office and you only see the PA or the nurse practitioner? How many times you guys gone to urgent care and you see the PA or the NP? And this is the model of healthcare because we're controlling cost. So we're promoting insurance companies, promote the middle provider because they pay out less. Hospitals and healthcare systems promote the middle provider because they have to pay out less in salary. And it's a win-win-win. The only person who loses is the physician and potentially the patient who has some complex issue that's managed by a mid-level provider. I think there are fantastic mid-level providers. I think having mid-level providers is amazing because it does help control costs. But where we get into issues is when mid-level providers are practicing outside of their designed scope. So again, the best intentions, bad outcomes. And I'll give you a practical example of how this happens. Are you guys ready? Maybe I shouldn't get into mid-level provider stuff. Is that too deep in the weeds for some of you guys? We'll do a separate video on mid-level provider creep. But the issue is, guys, is that they're being promoted because the economics of mid-level providers make sense for healthcare. But the problem is we're trying to focus so much on the economics that we're forgetting what mid-level providers are actually designed for, and we're spreading them too far into a scope of area where they don't have the proper expertise to execute. And that can be catastrophic to healthcare. And actually, I'll give you guys a real practical example. Urgent care. How many of you guys see urgent cares on every corner, everywhere you go? How many times you guys see urgent cares everywhere? Everywhere. The reason you see so many urgent cares is because they are ATMs, cash-making machines, because if you're in urgent care, you have all these visits that come in that are billable visits. You staff the clinic with mid-level providers, PAs and NPs. So you pay them a certain wage. Then, right, these PAs and NPs have to be supervised by a physician. Well, if you look at the laws around what supervision really is in these settings, it's only that the physician reviews a pool, a percentage of the overall patient seen, and only within a certain period of time. So it'll be like, okay, listen, this PA saw 100 patients this month. Okay, this is again an example. You have 100 patients you saw, so we'll call it 100%. The physician, to be called supervising physician, must review 50% of all the cases. And they must review them within 21 days or 30 days of them being seen. But if you're a patient going to an urgent care and being seen with your urgent issue, how does a physician reviewing that file 21 days or 30 days later help you? It doesn't. And so you get a lot of things that drop through the cracks, right? That's the issue. So as we promulgate and we push out all these middle providers, that's what happens because we're trying to control costs. What also happens is that physicians, right, when you're trying to control costs, is you have these insurance companies saying, hey, listen, physicians, we're only going to pay you for certain things. Only certain things. You didn't actually do any work here. All you did was sit there and you thought and blah, blah, blah. We're not going to pay you for your thinking. We're not going to pay you for your expertise. We're only going to pay you when you do something. And so what happens is then physicians, in order to get paid, have to do something, have to document. Someone asked me a question earlier about ICD-10s codes, right? These diagnosis codes. Like, what is that about? Well, if you're a physician and you want to get paid, you have to be able to document, I did this. If you can't document an ICD-10 code for something you did, then you don't get paid. That's how it works. And so therefore, physicians are incentivized to do stuff. And this is the facts, and this is the hard part of this. And this is why you saw physicians kind of going up, because they get incentivized to do procedures, to do things, because that's the way the model works. That's how it goes. And so you see this in modern day pan out, because if you guys, someone just on the box, like, I've only ever seen a physician, this is a physician assistant for orthopedics or urology. And this is super true. If you guys make an appointment for a surgical subspecialty and you go to their office, 9 times out of 10, you will see a mid-level provider. Why? Because the physician, in order to get paid, they get paid to cut. So an orthopedic surgeon gets paid so much because they cut. They don't get paid nearly enough to sit in clinic and advise patients. And so what has happened is the proliferation of the mid-level provider for ortho, the mid-level provider for urology, the PA, because they can go into clinic, make a reasonable wage, and doesn't drop their salary like it would a physician's being out in clinic. So you see this pushed in. Does this make sense to everybody? This mid-level proliferation, to answer Spencer's question. So mid-level provider creep is a result of our system and the economics of it, that, it makes economical sense to have them do as much as possible and have physicians do as little as possible because they bill less. Yes? Everybody understands where we're at right now. So that's what happens. And so you see all these different procedures, like, I think they can do that, they can do it, until something bad and catastrophic happens. And it's like, wait, let's pull that back. This is terrible. These mid-level providers, and there are phenomenal mid-level providers, but they have to stay within their scope of practice. Otherwise, it's a recipe for disaster. So anyway, the whole point of insurance now is to be a gatekeeper and to keep the costs of healthcare down. That's their function. And so now, how does that play into physician billing? Here we go. So if we can only control really the cost of that third of the pie, so let's reset this. $4 trillion in healthcare. 15% of our healthcare expenditure is on administrative costs. Those are increasing every year. 1/3, so then the other 85%, 1/3 of that 85% is on drugs and devices. Drugs are more expensive. Devices and procedures are more expensive, so you can't cut costs there, really, right? Unless you create a formulary for drugs. What we do is create a formulary. So if you guys have ever noticed this, right? Like you go and you're, I'm getting this drug. I'm like, actually, we've swapped it out for the generic. That's a cost control maneuver. That's how we keep the cost of drugs down. Oh, hey, you know what? You want to try this drug? Well, you got to try this drug first before you try that one, because that one's more expensive. It's a cost control measure, right? It's not bad. It's just that's the reality of healthcare. You have to control costs somewhere, so you try to do that. With devices, they say, listen, no. Before you can do that experimental procedure, you got to try this basic procedure first. Before we'll pay for surgery, you got to try physical therapy, right? That's how you control device costs. So drugs and devices, 31%. You can't really control that, so it keeps going up. You're trying to cap it, but you can't control it too much. Got to give people services. The other cost, the third, is the hospital costs. Now, this is what's important. A long, long time ago, there was a huge issue with people having access to hospitals. And so there was a couple legislative maneuvers put into place to increase the number of hospitals, to increase the access to care. Access to hospitals was problematic because, for example, you go all across town in an emergency, it's a problem. But it was extremely problematic in rural areas where there were no hospitals. And so you had a huge section of the population that weren't able to get quality access to quality care in a timely manner. And so there was legislation passed to promote getting more and more hospitals built. Okay? So now we have all these hospitals, and then hospitals started to compete, and they started becoming mega hospitals. And they got all these things, right? And so you got bigger and bigger hospitals, and so it's hard to contain hospital costs because hospitals are expensive and fancy and technology, all those kind of things. So hospital costs are hard to control. That last third of the pie is healthcare worker pay. The biggest part of that is physician pay. And so how do you limit physician pay? Well, you decide what physicians can and cannot do. The unnuanced argument here is that physicians are greedy, so we have to stop them from being greedy and overbilling. The nuanced aspect of this, and I want you guys to really understand this, the nuanced understanding you have to have about this is that if you were to go and ask 90% of physicians right now, how much a certain thing they do bills, they wouldn't know what the actual cost is, the true cost of it. So, hey, listen, I'm a heart surgeon and I do a heart surgery. Most physicians wouldn't know what the true billed cost of that heart surgery is. What they know is the piece that they see of that total pie. Yes? And so if I'm a physician and I don't know, and this is the problem with insurance, is there's a buffer there, we don't know what the exact cost of goods are. Both you as a patient, right? If I ask you, hey, how much does a heart surgery cost? I don't know, but my insurance covers a bunch of it and I have to pay this much. The patients don't know what something costs, and the physicians don't know what something costs, and there's a buffer in the middle of the insurance company that sets a price. So when both sides don't know the cost, you can't make cost-wise decisions. So if I'm a patient, I can't say, you know what, I should do, these procedures are about the same, I should pick the cheaper one, because you don't know what the cost is. As a physician, if you don't know the cost of the procedures, you can't choose the cost-effective option. So you sit and say, oh, you know what, we should start with this because this is less costly. You can't say that because you don't know what the cost is. And so as physicians, we're like, I like doing this procedure, I'm familiar with it, let's do this one. And the insurance company's like, nah, they gotta do that one first because that one's cheaper. And that's what happens. This is how the insurance company, they gatekeep. This is what happens. So this is important, right? So everybody understands. So the insurance companies there are guiding this care based on the cost of it. When you have this happen, and you have insurance companies deciding which procedure is most important, the problem is that most insurance administrators are not clinical, or not clinicians is the word I should use. And therefore, they are making a decision in a vacuum away from the patient about what a patient should be getting, even though they've been seen by a physician. And so they'll deny things, and the physician's like, oh my gosh, this is exactly what this patient needs. Why can't I get it to them? And there's a frustration factor there because you're like, man, I went to school for all these years and I can't give this patient the procedure I feel like they deserve. I saw them. I know what they need. And what the insurance companies are using pooled data and not the exact specifics of the case, and they can't quite understand what they're getting into. And so there's a breakdown there. At the end of the day, yes, insurance companies have to cover a bunch of stuff. So then what they start doing is they're saying, well, listen, yeah, we'll cover these, but there are certain aspects that we're not going to cover. So again, we're not going to pay you for this, we're going to pay you for this, we're going to pay you for this. And so the first squeeze, right, the big talk right now is anesthesia. We're going to get this anesthesia stuff because it's really cool. But the first physicians to feel a big squeeze were primary care physicians. Why? Because primary care physicians are not procedure-based. They're there to manage your conditions. They're there to talk with you, get your history, be thorough. They have to get all this large sum of data. They have to make tough decisions about what care you need, and they have to advise you and all that stuff. The sad part about healthcare is, because we're trying to control costs, is that these providers aren't paid for those services. So when you have a primary care provider, they're billing, they can bill a time interval. Okay, listen, yeah, this is a introductory visit, so it's longer, so I can bill for 45 minutes. Well, you know what, this is a follow-up, so I only get 15 minutes. Well, this is a complex follow-up, so I can bill for 30 minutes. And it's just a rough estimate like that. The problem is if you, the patient, show up to a follow-up visit and you got a new issue, how many times have you guys had your physician tell you, wait, this visit, we're only dealing with this, we can schedule you for another visit to talk about that. And the reason they do that is because of billing. Because they know if I sit here and I talk to you for an hour, I'm not going to get paid for any of that time. And it's just a sad reality, right? They don't get paid for that time. It's really, really unfortunate. Physicians don't get paid for advising you to be healthy. It's hard to bill for that. And so you are losing income. And so that's why you saw primary care physicians like, oh man, primary care doesn't pay enough. It doesn't pay enough because the things they do aren't procedure-based, and so they can't get paid for that. And it's a travesty because that's really what our healthcare system needs is more counseling, more preventative time, more mental health talk. More mental health talk. Why can't your primary care provider sit there and talk to you about mental health? And hey, what's going on in your life? What are your stress? Why can't we have this long discussion about what's going on in your family? And because we don't get paid for that. So what ends up happening is that physicians become like teachers, where they do a lot of things that they aren't paid for because they know it's in the best interest of the patient. Just like teachers know it's in the best interest of the kids for me to go out and buy all these supplies, even though it's out of my, my meager pay. Same thing for physicians. So I bet many of you guys didn't know that physicians, many of them don't get paid for their administrative time. So, for example, the big example, you guys would be shook by this. How many of you guys have an electronic healthcare system where you can message your physician? I'm gonna send my physician a quick message. And how many times have you been told, hey, listen, if you got a problem, message your physician, message your physician, message your physician. They want to promote messaging the physician. Did you know that most physicians don't get paid when they respond to those messages? It's part of their responsibilities, but they don't get paid for all those messages. And you might say to yourself, wait a minute, it's just one message. What's the big deal? Well, if you're a physician and you keep a whole panel of patients, 500, 1,000 patients, how many messages do you think you're getting every single day? Bing, 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 bing. How many times? How many of you guys are encouraged to message your physician to get medication refills? Did you know that they get a decreased reimbursement for filling your medication, even though they have to take the time to look at your labs, look at your, see what's been happening, and make sure, does this make sense? So they have to do all this clinical thinking, but they get a decreased reimbursement because they didn't see you in person to make that charge, that change. That's outrageous. But it's a cost controlling maneuver to help our system function. When you move into specialists, what ends up happening that are more procedure based, that are higher pay, there becomes this public narrative of, oh, these are greedy specialists. They're just trying to bill, they're trying to bill, they're trying to bill, they're trying to bill. And we fail to recognize the nuance, the layer in here of what we're actually getting paid versus what we're actually doing. And anesthesia is the perfect example of this. If you guys didn't see, recently, an insurance company tried to have a policy where they were going to chomp down on these overbilling anesthesiologists, because anesthesiologists are paid partially, and I'll break it down, partially based on time. What they were saying was that anesthesiologists are milking the clock to get extra pay. That was their argument. And this argument is nonsensical. It would never happen. I'll break that down for you too. But that was their argument, that these physicians were overbilling. And what these insurance companies fail to recognize is the nuance of the anesthesia job and the fact that there's so much that we don't get paid for already. And so to understand all this, you have to understand how anesthesia insurance billing works. Again, I'm a practice owner. I do billing. I understand this stuff. For anesthesia, when you do a case, so let's just say, we're going to do a knee replacement. As an anesthesiologist, you get paid two ways. The first is you get paid a start units. So you get paid a certain amount of dollars based on what type of case it is. So you can imagine a heart case pays more than a knee case. A brain case pays more than an elbow, whatever, right? You get paid on the difficulty of the case. They say, listen, this is a real hard one. We're going to pay you a little bit more to do this very difficult case. So you get a start value of the case. Then you get a second fee based on time increments of that case. But the biggest payment comes from the start value of the case. So as an anesthesiologist, that's the case, right? If the biggest value comes from the start value, what is my incentive as an anesthesiologist? Do I want cases to go long or short? I want them to go short because I want to maximize the number of cases I do so I have the maximum start value. It is better to be, this is crazy, it'll blow your mind. You could do one heart case as an anesthesiologist and take you all day. That one case would pay you less at the end of the day than if you did colonoscopies all day for the same time interval. Why? Because you could do 30 colonoscopies in the time it takes you to do one cardiac case. Is that crazy? So it's the start value, not the overall time. When the insurance company makes the argument that the anesthesiologists are milking the clock, it doesn't make sense economically from the anesthesiologist's perspective. Why do I want to do that? I want to start at the next case. It also doesn't make sense from a hospital efficiency perspective. Anesthesiologists don't have our own patients. If you guys understand what anesthesiologists do, we're a consultant specialty. So I don't have a panel of patients as an anesthesiologist. My patients are the surgeon's patients. I never say, my patient. No. The surgeon's patient, that's their patient. So the surgeons are in control of the patients. and they decide who the anesthesiologist is, what departments to work with. So the surgeons have to be happy with the anesthesiologist, otherwise it's a bad day. Surgeons get paid to cut, and it's the same premise. The more they get paid, okay, you get a set fee for doing a knee, a set fee for doing whatever. So the surgeons want to do cases as fast as possible, get them done to have maximum productivity, as many cases as they can. So if the anesthesiologists were just standing there with our hands like this, doing nothing, milking the clock, the surgeons wouldn't have us work and would fire us, would terminate us, would block us, all these things. So it's not logical that anesthesiologists would milk the clock for more time. Yes? The insurance company argues, well, listen, sometimes these cases are lasting this long, and these cases are lasting this long. How can that be if it's the same surgical procedure? Let me break it down. Anesthesiologists. How many of you guys think anesthesia does nothing? I got so mad the other day because I'm like, this is why everyone thinks anesthesia does nothing. I was watching a show called New Amsterdam. My wife likes these medical shows, Grey's Anatomy, all these kind of shows. And I always have to turn them off because you know who's never prominently featured in any of these shows? The gosh darn anesthesiologist. When's the last time you saw an anesthesiologist do something of impact and import, right, in one of these shows? Never. You never see the anesthesiologist. When you think about an anesthesiologist, people think about the guy who sits in the corner and does Sudoku and crossword puzzles and so forth. That's what people assume anesthesiologists do. But what anesthesiologists do, the reason it looks like we're doing nothing, is because we get paid for our clinical knowledge and expertise and ability to avoid having to do something. The same reason I'm an amazing pre-med coach is the same reason I'm an amazing anesthesiologist. Because I'm a planner, I'm a preparer, and I am a person who likes to sit down, think about something in a very thorough manner, and then build a foolproof plan for success, whether it's getting you to medical school or it's getting a patient through a case. And anesthesiologist is like a referee, y'all. In any sport, if you know the referee's name, that referee's a problem. Because that means he's doing something out of the norm, and you're like, what is this referee doing throwing a flag right there? What's the referee calling that foul? You're upset about something. It's the same way with anesthesia. Our job is to be invisible, like we're not doing nothing. A good anesthesiologist should look like they're doing nothing. And everyone knows, right? You see, if you guys are in healthcare, you guys would know this, right? When you guys go into surgery rotation, if the anesthesiologist is standing up or sweating or moving around, you know someone's about to die in this place. You know danger. Is that death in the air? Because the anesthesiologist should not be moving like that. A skilled anesthesiologist is so skilled at mapping out all the potential dangers and avoiding all those dangers and setting the case up perfectly that it looks like they're doing nothing. But it's because they spent all that time planning. That's what happens. And people don't understand the difficulty of what goes into anesthesia and planning a plan, because when you give anesthesia, the way anesthesia works is we're turning the brain off to allow the patient to be able to go through a surgery and not move, not be in pain, and not remember what they just went through. Right? Imagine how it would be if you could remember, oh, they burst my chest open and they were working on my heart. Like, it'd be awful. The pain, the horror, right? So it's my job to make sure that you go to sleep, you stay asleep, and you don't remember getting your chest cracked open like you was in an alien movie. Right? That's my job. And so to do that as an anesthesiologist, I have to make a plan to make that happen. And while it may seem straightforward, it's not, because when I turn the brain down to make you not respond, your brain and your nervous system actually control all of your organs. So when I turn the brain down, almost off, it turns the organs down and almost off. So your heart rate drops, your heart function drops, your breathing stops. You can't breathe for yourself during surgery, right? Your GI system shuts off. Your kidneys and bladder don't work like they normally do. All the major systems of the body shut down, slow down. And so it's my job as an anesthesiologist to turn them all down and then play puppeteer and be your organs during the case, making sure those organs do what they're supposed to do under my puppeteering. And you do that in such a way that you see and you foresee, oh, you know, the lungs are going to turn off here, so I'm going to pre-oxygen and give lots of oxygen to make sure the lungs aren't really impacted with the body. Boom, boom. And you move through the process. That's the way it works, right? And so it's your job to make this plan. But the problem is people don't understand the nuance of anesthesia. And so as anesthesiologist, I only get paid to start the case and then the time interval. But the nuance is lost. And so we'll start here in the basics part of it, is for the insurance company. They say, listen, how can this procedure take this long for this patient and this long for that patient? Well, every patient is unique because as the anesthesiologist, I have to look at, okay, what is the case? So what does the surgeon need for me to deliver? Okay, at the same time, how can I deliver that? I have to look at the patient and see what their baseline is and see what they can tolerate. And every patient is not the same. And so therefore, their course of surgery and their course of response to anesthesia is different. And so you might say, wait a minute, let's just say you're doing a knee procedure. Okay, listen, we're gonna do a knee replacement. Okay, cool, knee replacement. A knee replacement in a 20-year-old healthy guy who just happened to get his knee hit by a motorcycle. That's easy. I can do it with my eyes closed like this, okay? But now, if we're doing the same knee replacement in a 65-year-old man who has smoked his whole life and has severe COPD, who had a heart attack 6 months ago, is that the same procedure? What if that same patient had a GI bleed 3 months ago or a GI bleed this week? Maybe they were in a car accident. I don't know, right? What is that the same case? And it turns out it's not, because if you have a severe COPD cardiac guy, I've got to go through all the charts. And this is crazy. I don't get paid for any of this stuff. Before every case, I have to go through all the charts and I have to look at all these reports. I have to do all these things. I have to coordinate the care. I say, listen, I still need this. I don't have this information. I don't know if I'm safe. I have to do all this stuff and I don't get paid for any of that stuff. I get a start unit and I get a time. So all this stuff that happens, I don't get paid for it. None of it. But all that time I put in saves lives. And I'll give you guys the perfect example. You guys ready for this? This is how it went. This is last week. Okay. So I had a kid who's going to undergo a procedure. It's an outpatient surgical procedure. No big deal, really, for most kids, right? But this is a kid. This kid is 3 years old. Okay. I have this patient. So I'm like, okay, before I see the patient, again, I only get paid when I see the patient, start time and the time I have the patient. So I hear I have this patient. So okay, well, let me do a chart review. So I go into the chart and I'm going through this patient's chart. And the first thing I see is patient cleared for surgery by cardiologist. Now, you might be like, oh, that's cool. Cardiologist said he's good to go. For me, I'm like, whoa, why does he need cardiac clearance? So now I've got to go down a web of weaves to figure out why this patient had to go to cardiology. So I go back, PCP visit. What happened? Well, it turns out this PCP, the primary care provider, the pediatrician, heard that this 3-year-old had a heart murmur. Now, it is very common for little kids to have benign heart murmurs. No big deal. Oh, I heard a heart murmur, let it go. The next thing you do, right, when you hear that heart murmur on another visit, you're like, I still hear it, is you order an EKG, an echocardiogram, right? You order this and they put stickers on the chest and they look at the heart's electrical activity from the outside. So it's like taking a picture from really far away. It's not HD. So their pediatrician ordered the EKG. The EKG showed that this kid had electrical activity consistent with right ventricular hypertrophy. Okay, so now you've had an abnormal sound, and then the EKG could either be normal or not normal. If it's normal, you're like, okay, go ahead, whatever with your life. But now the EKG is abnormal. Looks like you have right ventricular hypertrophy. I'm like, ooh, I hear right ventricular hypertrophy. That freaks me out as an anesthesiologist because the right side of the heart is very difficult to manipulate, and people with sick right hearts die in an instant. It's very, very quick. Very fast cardiac collapse. Okay. So I see that. I'm like, ooh, let's keep reading this story. So all this time, I'm going through this whole chart, all these records, all this stuff. We get to the cardiology visit. The cardiology visit was 3 days before this patient showed up in the clinic. So this was last Thursday, 6 days ago. They saw cardiology on Monday of last week. Cardiology note reads, yes, I hear this patient's murmur. It is blah, 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 blah. They describe it like cardiologist, all these different sounds they're hearing, right? Yes, they have a murmur. Additionally, the EKG is concerning for right ventricular hypertrophy. Based on that, I am recommending that this patient undergo a cardiac echo. So we're going to take an ultrasound and we're going to look inside at the actual heart to examine if there's something serious going on with the heart. Then they close the note by saying, patient scheduled for procedure later this week, outpatient minor surgery, patient is okay to proceed. So I'm like, uh-oh, that's not good. This patient was cleared by cardiology, even though the cardiologist wants to order an echocardiogram to see if there's something more serious going on. So then the patient shows up in the office. They're there for the appointment. I'm checking this. All the while, they're out there waiting. I'm delaying the day, not getting paid, right? This whole chart review takes about 20 minutes. I'm going through all this stuff. So then I'm like, oh gosh, I got to cancel this case today. They have an echo pending. They're going to look at this guy's heart. I don't want him to die out here. It's outpatient minor procedure. So I walk out there and I try to explain to the family, hey, listen, I'm your anesthesiologist. I was just reviewing the chart and your kid is 3, is scheduled for an echocardiogram. So because of that, we can't do this procedure. And the mom proceeds to start yelling at me, and it turns into a literally 30 minutes of the mom yelling at me, the dad yelling at me, the kid is crying. I'm trying to explain my position for why I'm canceling, and she's upset with me because she's like, if he has cardiology clearance, there's nothing wrong with the heart. And so I'm trying to explain this process. Then I walk them through, here's my chart review. Bop, 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 bop. They hear a weird sound. They didn't do an EKG to see if it's normal. It's not normal. You go to cardiology and say, yeah, it is concerning. I want further testing. I can't put you to sleep because what if there really is pathology in your right heart? It's bad. So this whole argument, this whole time, it's been an hour now, right? 30 minutes, 20 minutes of chart review, 30 minutes of this. I get paid for none of that time. Additionally, this patient was scheduled for a 3-hour procedure. I cancel the case. The surgeon's upset. He got cardiology clearance. Surgeon's mad at me. Family's mad at me. And I don't get paid for that hour. And guess what, guys? Because I canceled the case, I don't get paid for the next 3-hour block until the next patient gets there. So I lost out on 4 hours worth of income, and everybody's yelling at me. But was that chart review, was that counseling the patient, was all that stuff important? Potentially life-saving? Well, it's not even potentially life-saving, it actually is life-saving. Because you fast forward to this week, I'm chart reviewing because I want to see this echo. Because I got yelled at. Well, the kid went and had the echo this week. Guess what the echo showed? That this kid has a valvular abnormality that's resulting in regurgitation on the right side of the heart and his right ventricular hypertrophy. And so now, right, the next thing is they got to go work this up and see, wait, is it a lung issue? Is it a core heart issue? Is it blah, blah, blah? There's an issue with the right side of the heart. So imagine if I didn't, 1, do the chart review, 2, supersede the cardiologist's clearance for the procedure, 3, be willing to have the patients yell at me, 4, be willing to have the surgeon yell at me, 5, be willing to lose out on 4 hours of income. What would have happened to this kid? But the insurance company doesn't pay me for that. That's the difference, guys. That is what happens. Today, okay? It was a wonderful, glorious day. I had a patient who was assigned to me, said Pinesett only, Pinesett only, Pinesett only. Why? Because this kid, I say kid, he's a 24-year-old adult man who's over 100 kilos, so he's over 200 pounds, and he's severely autistic, nonverbal, self-injurious, violent. So this guy's over 200 pounds, nonverbal, likes to hurt himself and hurt others. They assign him to me because I've developed a reputation for being able to handle difficult situations gracefully. This case, standard case, right? Should take 2 hours, a 2-hour case. But this guy, this is so important, guys, right? Super bad behavior. So what does that mean? Well, we got to try to control this behavior. So how do we do that? We medicate them. This kid is on 4 different psychoactive medications. 4 different medications to help control his outbursts. He's on an antipsychotic. He's on a seizure medication, right? He's on a antidepressant. He's on an anxiety medication. He's on all these different medications. He's on a clonidine. He's on like 4 different medications for his psychological issues. He's also on a muscle relaxant for his TMJ. And the way a muscle relaxant works is it turns the volume down. And many muscle relaxants are also psychotropic drugs, blah, blah, blah. So he's on that. So now he's on 5 agents that affect the brain. Additionally, you have this kid who's combative, who's self-injurious, will hurt other people, and he previously took the other provider's hands, bent their fingers back, causing issue and having caused them to be out of work on the previous visit. So now I have to be like, straightforward procedure, but I've got to make this procedure happen for this kid. And I'm the kid's last resort, because if I don't do it, nobody's going to do it. So I'm like, let me sit back and assess this. Again, I only get paid for start time and the time I'm actually in the room, but I'm not going to rush it. So I draw up ketamine. Ketamine is an amazing drug because it keeps the airway open, but it allows you to put people in an incapacitated zombie-like state. I call it the K-hole, right? The ketamine hole, like a zombie. My plan is I'm going to stick this kid with this ketamine dart and give him an intramuscular injection. I'm going to bam, walk up and stab him real quick. And then he's going to fall asleep. Now, just a few weeks ago, a patient got very, very hurt when someone, an anesthesiologist, attempted a ketamine dart, is what we call it. Why? Because you can't just give someone a medication that knocks them out if they're big and you're in the lobby or you're wherever. This kid is so combative. He knows what's up. He's not coming in the office. So the kid is actually outside the office in the hallway. So he won't come into the surgery center. So we're not in the operating room. We're not even in the waiting room. We're out in the freaking hallway on the hard tile floor. So if you inject this guy with a large amount of ketamine, you put him out instantly, he'll slump and crack his head, do whatever. And this is what happened previously. So the skilled anesthesiologist I am, I said, no, I'm not going to do that. Here's what we do. I'm going to have a plan. So okay, wait. How do I stick this big old 200-something pound person with this sharp needle? They're going to run from this, so I got to sneak attack them. So what do? I get a bunch of cotton balls. And I take the cotton balls, and I throw the cotton balls up into their face space. And they're doing this with the cotton balls, and while they're doing that, and the cotton balls fall, and they're looking over here, and while they're doing that, I take my needle out, and I jam it in their leg. Bam! Get them right in the thigh. And stick the needle in there. Inside that syringe is not the full recommended dose of ketamine that you would use as a pre-induction medication to put someone out. Because I don't want this big old 200-something pound guy falling on the floor and bumping his head. So instead, I gave him a third of that normal dose. Not enough to knock him out, but it is enough to make him compliant. And so my plan is not to knock him out, to make him compliant. So I give him that medication. The medication doesn't kick in right away because it's a small dose, big guy. So he's like, and he's angry, and he's upset, he's going around. And I'm like, hey, you're okay. So I'm just like maneuvering around, make sure he doesn't hit his head, and controlling him. Oh yeah, he's upset. Okay, oh, don't hit me. Keeping it light, and we're just existing in the hallway. Now I start to see the eyes flicker a little bit. I'm like, oh, it's might be our chance. Hey, bud, come over here, sit in the wheelchair, sit in the wheelchair, sit in the wheelchair. No. Like, come on, in the wheelchair. Right? I'm like, oh, he's not ready yet. Keep going. So that was already 5 minutes. Now we're at 6, 7, 8. Took me 10 minutes-ish to get him in the wheelchair. Finally get him in the wheelchair. I'm like, perfect. We're rolling to the OR. Start rolling him. He's like, no. He sees the door. He's up, out of the chair. I'm like, oh. So I'm like, okay, he's out of the chair. So I'm just going to wait. I'm like, okay, let's walk. So now I'm walking behind the patient. I'm guiding him because now he feels in control. I'm guiding him to the operating room. So now we're walking through the lobby. Everybody's out there. Like, hey, guys, don't worry about this. Right? I'm walking through. We get to the operating room. Now he refuses to get on the actual bed. I'm like, no. So now we're standing there and we're just kind of existing. And then finally I'm like, oh, I see more eye flickers. I get him on the bed. And all this time, over 20 minutes has passed. Finally get him on the bed. He won't let me mask him down and put the anesthesia on and put him to sleep. No. I'm like, wait more. 4, 5 minutes, 6 minutes. Okay. Finally, he's like starting to come back. So then I wrap my arm around him, protect him, love him close, and slam the mask on. And I'm holding him. I'm like, right now, oh, boy, I'm doing all this. For another three-ish minutes, he's asleep. We're out. Kid's asleep. Parents aren't hurt. Staff's not hurt. Patient's not hurt. I'm not hurt. Nobody's hurt. But it took me over 30 minutes to get that induction done. A typical induction like that takes 5 minutes. It took me over 30 minutes, right? So like a normal, if this kid was a typical kid who would cooperate and whatever, the whole induction takes 5 minutes. It took me over 30 minutes. Guess what, guys? I get a fixed fee, the start fee, and then I get a small incremental bump for that extra time. But we don't consider that factor. So now it's, instead of a 5-minute induction, we got a 30-minute induction. But now I've given this kid ketamine. He's on 5 different psychoactive medications. We do the whole procedure. At the end of the procedure, during the procedure, I have to titrate medications down to get it just right to hopefully get him up and out. But what happens in a lot of these cases, they're on all these medications, so then they're snowed, and then they wake up super slowly. And my question to you is, right, if I were to drug you up, give you a bunch of drugs at your house, give you a bunch of drugs and then leave, would you want me to do that? Give you the Michael Jackson treatment? No, because you'd end up dead, right? All these fentanyl overdoses, it's people giving themselves, being their own anesthesiologist, giving themselves fentanyl, and then no one's there to supervise and they die. And so I tell everyone, anesthesiologists don't get paid to give medications. Anesthesiologists get paid to monitor you, to see that you tolerate that medication and that you stay alive after you take that medication. I love fentanyl. Everyone's like, fentanyl is killing America. Fentanyl is my friend. I love fentanyl. Ooh, I can't get enough fentanyl. Right? I love fentanyl. Why? It's magic. It relieves. It's great for blunting the airway response. It's great for pain management. I love fentanyl. If I could, I bathe my patients in fentanyl. Fentanyl for everybody. Everybody's getting fentanyl because it's amazing. It's amazing because I'm an expert in managing the effects of fentanyl on your body. So when you go apneic and you stop breathing, you don't die. I got you. I jaw thrust you. I got you. I'll put a tube in. I got you. Oh, when your heart starts to slow down, don't worry, I got you. I'll give you a little bit of this ephedrine. Pump that heart rate up. Don't worry, You're good. You're good. You're all right. You're all right. Oh, I'm going to breathe for you. You're not breathing. It's okay. I got you. I'm going to bag you. You're all right. You're all right. Oh, goodness. Oh, your bowels are a little slow. Don't worry. I got a bowel regimen for you. I got a bowel regimen, baby. Get the bowels going. I manage the fentanyl. So I love it. Right? But you would never want to be sedated and have someone leave you. That's how people die. So if I'm an insurance company and I say, hey, listen, anesthesiologist, hey, this procedure should only take 2 hours. If it takes any longer than 2 hours, we're not paying you. What does that do to the anesthesiologist? That 30-something minute induction, I'm not doing that. I'm just going to slam the ketamine. Maybe it's his head, maybe it doesn't, but I got to go. The insurance company said only 2 hours. Only 2 hours. They don't consider this. Afterward, patient snowed. He's on 5 different medications. I had to give him all this ketamine. I had to add this because now the ketamine, that's 6, plus the propofol I'm giving, plus the fentanyl I'm giving, plus all these medications. Oh, you know what? He's snowed. Hey, my time's over at 2 hours. I got to go. And I leave. No. Instead, I make sure that patient wakes up, is breathing independently, spontaneously, can protect their own airway, can follow instructions, and can get themselves in the car without hurting someone. All these things to make sure the patient is safe. Does it take longer than a normal case? Yes. Am I milking the clock, or am I treating the patient as they would want to be treated, as you'd want your loved one to be treated? That's what's happening. But when you set arbitrary time limits, who gets the shaft? The provider and the patient who's not being treated according to their specific condition. You have to treat the patient, not the profile, the patient. That kid had a great outcome, guys. He got up, listened to my commands, got him in the wheelchair, got him in the car, he got himself in the car, and he went home. Parents were happy as pie. Mom was squeezing me. Oh, thank you so much. We thought we were blah, blah, blah. It was wonderful. It was a beautiful day. But think about things, guys. Physicians are not greedy. Physicians work very hard, sacrifice a lot of years, time, learning all this stuff. Do you guys know how, this is going to be weird to say. Can I say this to you guys? Is this okay? Is this a safe space? If this is a safe space, like this video right now. Let me know you guys still with me. We're at exactly an hour. Can I say this in a really safe space? I say this to my wife all the time. And she's like, yeah, you're right. I've seen you. She's like, I've seen you do anesthesia. I know what's up. I said, man, I have learned a lot. I am very, very expert. She's like, yeah, you right. I said, yeah, I am. I just sometimes I marvel at how hard I've pushed myself to learn so much. And that's why I'm so proud of it, because I'm like, my brain isn't the best brain. I became an elite studier because I committed myself to learning how to study and how to learn things fast and how to retain things and whatever. It takes so much effort and strain and sacrifice to become a highly experienced physician. It's really sad to me when we belittle PhDs, when we belittle MDs, and we devalue education, and we act like, oh, just because you educated don't mean you know stuff. Well, actually, that's kind of like the definition of education. Like, if I'm educated, if I've trained in medicine, I kind of know my medicine. I'm not right. If I'm willing to give 4 years of college, if I'm willing to give 4 years of med school, 4 years plus of residency, if I'm willing to do all these things and rack up hundreds of thousands of dollars in debt, I think I've earned the right to be able to use my knowledge to help my patients the best I can. I'm proud of the fact that I'm an expert, and I feel like our healthcare system and the healthcare economics devalues expertise. It devalues critical thinking. It devalues looking at the nuances of a patient and designing a specific plan to them. And this is why you see so many people rebelling against healthcare right now, right? And they want their concierge medicine. They want their, right? The next wave of medicine is genetic-based medicine. We're talking about specifically treating the patient. So why, if we're talking about the future, the frontier of pharmaceuticals is in tailored medications, why wouldn't the future of clinical care, of physician care, be patient-centric care? Why do we separate the two? Why do we devalue the fact that I'm trying to do nuanced, high-level, specific care? I believe in the art of anesthesia. And yes, not just waking a patient up. I want them to have the best day of their gosh darn life. I want them to want to have surgery every day. That's how good I want their day to go. I want them to feel safe and comfortable. I want them to feel pain-free. I want them to feel like, man, because you guys know, well, you guys might not know, but if I told you, hey, you have to have surgery tomorrow, oh, you'd be scared. Scariest day of your life. I never had surgery before. And it truly is. That's why I love anesthesia, because it's the scariest day of their life. And I get to go in there and I get to make them feel like it's going to be okay. Here's my plan. I articulate it to them. It's the same thrill I get from working with students. I love it. You guys are scared. Am I enough? I might be, it's not good enough. The course is too hard. And I say, no, I got you. Here's the plan. And when I see you guys' faces light up when you have a good plan, when I see you guys' face light up when you get the acceptance, when you guys succeed and get the white, like, it's a beautiful thing, because I'm like, I did that. I created certainty. I created surety. I created confidence. I created an opportunity for someone to have a great, tremendous experience. That's what being a physician is truly about. And so for you guys as young people, recognize these economic pressures, and first and foremost, don't fall into economic pressures. Never be about the money, y'all. The money will sort itself out. Always put the patient first. Yes, was I getting pressured to that case? Yes, 100,000%. But you can't pressure me into doing something that's not in the best interest of my patient. Can't do it. And it's the same for insurance companies. This is how it goes, right? So I mentioned I do all these cases. This is how the billing works. As a physician, you have to pre-authorize what you do. Hey, listen, yeah, I want to do this surgery on you, or I want to do this anesthesia. Okay, we got to send it to the insurance company and make sure they pre-auth it. So I have to sit down, and I have to write down all the diagnosis codes, and I have to write a narrative. It's called a narrative note. I have to write a story that persuades the insurance company of why my patient needs this care. Then the insurance company writes back and says, hey, listen, you know what? We're not going to approve it, or whatever. A lot of times they approve it. Oh, here, pre-authorization, we approve it. You're right. They need anesthesia. I'm like, great. So now they've already approved. They said, listen, they need anesthesia. Do the anesthesia. I do the anesthesia. You would think they would just pay me in advance, or they pay me when I did it, but they don't do that. I then have to send all the records, all the documents. I have to write further narrative. I have to tick all these boxes and document the codes, and then have a narrative that justifies why this code was applied, and blah, blah, blah. Do all this stuff. Then I have to fill out their specific forms and use their codes. I have to send all this to the insurance company. Not electronically, snail mail. The insurance company then reviews it, and they have 90 days to review it, and they get back to me and say, listen, we're not really sure. Like, really, did you need to keep them asleep for that long? You said you used ketamine. Did you need to use ketamine? And then what do I have to do? I have to argue with them. Yes, I had to use ketamine. The patient was combative. The patient was blah, blah, blah. As I explained previously in my narrative, the patient was combative. The patient was blah, blah, blah. They needed this. I sent it back. Well, then why did induction take 30 minutes? It took 30 minutes because I couldn't ketamine works very quickly. Yes, but I couldn't just give them a full dose of ketamine because of this. Well, then how come you wash them? I had to wash them a little bit longer to make sure they were safe because they're on all the medication. Like, why do I have to argue with you if you've already pre-approved it? Why do I have to go and get at this? And someone said, doesn't Medicaid and Medicare, Medi-Cal, doesn't this stuff pay great? And the truth is, the sad truth, is that government insurance pays less than what private insurance pays. And this is why a lot of offices don't accept Medicaid and Medicare, because it's lower paying. That's why a lot of offices only accept private pay. They want the real, like regular insurance, not the government insurance. And that's the truth. And so what happens? Who's on Medicare and Medicaid? The oldest, the poorest, and the sickest. The most vulnerable of our population are on this insurance. Is that what you want? It's not what you want, right? You have a lot of physicians who would love to take insurance, but it's just too complicated, so they don't. And I'm going to have a physician on either later this week or next week talking about how she only takes cash in her business, in her practice. And for me as an anesthesiologist, I take government insurance. I'll take Medicaid. I will not take private insurance. So if you are a patient and you don't have Medicaid, because Medicaid has one set of systems and I can do that and I can handle that. All these private insurance companies, they change their billing, they have all these intricate policies. It's too much legwork for a small practice like mine to have to do. So I don't accept private insurance. I pre-auth, and then, right, they get the approval, and then I tell the patient, hey, even though you pre-authorized and you're good, they're approved of this procedure, you have to pay me cash on the day of. Then you go claim and go through the process the physicians go through to get your money back. And it's amazing how many patients, I even write out a full script for them. I give them all the codes. I said, listen, read this line by line to the insurance company. Hey, my kid had blah, blah, blah on this date by this guy. Here's his national provider ID number. Here's his blah, blah, blah. Like, here are the ICD-10 codes. Here's the length of intervals. I give them all the whole script. And you know what the insurance companies be saying? We're not familiar with those codes. And it's this whole rigmarole. And the patients call me back like, man, why is the insurance company doing this? I thought they pre-authorized this. I'm like, hey, this is the struggle that all these physicians, all these hospitals, this is the struggle of healthcare, is that you have the economics don't always match with what the patients need, what the providers need. And sadly, and this is like the craziest part about this, is everyone wants to villainize insurance companies, and I can't really villainize them for doing what they got to do. But this system doesn't even work for the insurance companies. And the way you know it doesn't work, and this is the last thing that we'll end here, because am I going too long? Like the video if you're still with me. Do you guys know they create all these healthcare exchanges through the Affordable Care Act? And if you guys have watched these healthcare exchanges, when it first came out, it was amazing because there were all these new insurance companies in the game, because that was giving an opportunity, a platform to be able to see by eyeballs. But over the time, all these new insurance companies have actually folded and gone out of business, most of them. Why? Because they can't compete on a scale administratively and capitalize with the existing insurance companies. And so what it shows you is, right, in any industry, if new companies can't enter, it tells you that the insurance companies are struggling. And I make fun of, and I say, hey, listen, they're profiting like crazy. Yes, they are. But at the same time, do you know how hard they're working for that profit? It is very hard to make money in health insurance now because we went from catastrophic coverage to having to cover all these little things for all time. Right? And the biggest example of this, guys, I can give you guys a million examples. Do you guys know what one of the biggest, unforeseen costs of care is in healthcare right now? HIV medication. You guys see Magic Johnson, right? Over 30 years, HIV positive, thriving. HIV was a death sentence, but now you have people taking very complex, not very expensive, but expensive HIV regimens for decades and decades and decades and decades. It's very expensive. You know what else is you know what the number one condition? You guys know what the most expensive condition is in healthcare? Obesity and obesity-related conditions, right? We're an obese society, and the cost of caring for and keeping obese people alive is crazy. High blood pressure, right? Hyperlipidemia, right? High cholesterol, right? Cardiac issues, pulmonary issues, obstructive sleep apnea, you name it, go down the list. Debility, right? Deconditioning, you name it, across the board, it costs us to manage all these chronic conditions. And so I think as we end, and I'll close, I'll say, yes, I blame the insurance companies, but I more so blame our system and the fact that we won't just tear it down and start anew to really get some things right. And at the same time, we have to recognize as people things that we can do to cut down on costs. And so we didn't really get to this, but maybe we'll do one more of these sessions in addition to the interview I'm going to do next week. I'll do a couple of interviews, but where I talk about the real true solutions, and we'll get into the nuance because it's very, very nuanced. And I don't want to bore people to death. I hope that this has been entertaining. But if we got into, I haven't talked about really the specific, like, I could bore you guys to death on the specifics of this. What I'm trying to do is keep this high level enough to where everyone can understand what we're talking about and understand the big pictures of this, but understand enough of the meat to where they can, like, okay, that makes sense. He's actually talking facts here. But we're going to talk about some very nuanced solutions. And all of these solutions, before I even give them to you next time, understand you're going to be like, this guy is gosh darn nuts. Never in a million years will we do that. And it's because like in life, right? For you guys as pre-meds, as students, the best decision, the best action, very frequently is the hardest action. Becoming a doctor, I had to make lots of difficult decisions. I had to take lots of difficult pathways, a lot of paths that people didn't want to take. I had to go the road less traveled, the more difficult road. But that is life, y'all, and that is healthcare. And we got to make some very difficult decisions and make some changes that people, both on the patient side, on the care provider side, whether physician, middle provider, whatever, on the insurance side, on the administrative side, no one's going to be fully happy. We're going to have to compromise and come together, and everyone's going to have to suffer a little bit so that we can all sustain our healthcare and make it sustainable for their future. Yep. Yeah. William says, as a transfer student, I'm really concerned about the cost of transferring to a university. Y'all, listen, life is expensive, but I've never regretted spending a dollar that was invested in me and my future. I've regretted buying expensive stuff, but I've never regretted paying to feed my brain. I've never regretted paying to nourish my body, because you only get one body, you only get one mind, you only get one life. And so I encourage all of you guys, never be afraid to invest in your education, guys, because education is the way. Education is the way. But with that being said, with your education, you need to couple that up with experiences, with true knowledge. You have to become the expert. You have to know more than just what the book says. You got to understand what that means in the real world. And that's the key. And if you do that, guys, I know he said nothing's guaranteed. You know what is guaranteed if you apply yourself is that you'll be successful. People who apply themselves, people who work hard, they don't fail. They'll get there. So invest in yourself, guys. Invest in your future. Don't spend frivolously. I know the social media culture got you gassed up. You see everybody in their fancy scrubs, everybody wearing fig scrubs. I don't own a single pair of fig scrubs. Because I thought it was jacked up, that campaign they did way back when. I did a video on that, and I'm the only one who stood by it. Everyone else is like, oh, listen, I'll never wear figs. They're discriminating against women and against all those same cats got figs deals now. You think Figs hasn't contacted me for a figs deal? You think I can't be modeling fig scrubs? But I refuse. I'll never wear figs. Why? Because they wronged us back then. But secondly, it's a waste of money. Why would I buy those expensive scrubs? I can buy a cost affordable scrub. Don't let social media gas you up and spend all your money on stupid stuff. Spend money on yourself, invest on yourself and on your future, on your kids' future, on your family's future. That's where you put your money at, y'all. All right, was this a good topic? I'm kind of hoarse right now. I'm in an hour and 15 minutes. I hope that everybody. No MCAT session for the end of the year. We got MCAT coming up in January. It's holiday time, y'all. Y'all don't be showing up for coaching during holiday time. But if you have a question specifically, email me. Send me an email about MCAT, whatever. We'll talk about it. But I appreciate y'all. We'll be back next week. I got some good interviews coming in with you guys. We're going to talk about this. I have some great stuff. Are you guys excited? We're going to do a lot of interviews on the Premier Productivity Podcast this upcoming year. I'm excited to bring you guys some voices. I'm excited to bring you guys some strategies, some stories of inspiration, and I'm just excited to bring you guys more content. So I hope you guys are enjoying this. Please come support every single Wednesday. There will be a new video on this channel, whether I'm live or I'm pre-recorded. There will be a new video on this channel every Wednesday at least. And actually, I'm going to try to get up 2 videos a week. But I know that you guys need real stuff. I'm hoping to bring real stuff and we can talk about some things. So as always, guys, have a wonderful, wonderful day. If you guys want to get with me, if you're like, listen, Dr. Pinesett, I need more of you. If you're like Cool Gray and you're in my MCAT course, right? And you're like, oh, listen, if you want get coached by me, get to my website, premedproductivity.com, and get into a course, get into a coaching program. My MCAT, it's a program. You course, you coach it with me. It's amazing. So I hope that everyone has a wonderful evening. I hope everyone's having a great holiday, staying positive, staying productive as we go. But I'm out of here. Everyone have a wonderful day. I'll see you guys next time.
That's it for another episode of the Pre-Med Productivity Podcast. Show your love by smashing the like button and commenting in the box below. Today is the day, guys. No more excuses, no more complaining. You're going to take your future into your own hands. You're going to dominate. You're going to be successful. I challenge you. What are you going to do today to make your life better? Get to my website, premedproductivity.com. Grab a free ebook, sign up for a free webinar, and if you're really ready to transform, enroll in one of my life-changing courses or coaching programs. You have greatness inside you. Let me show you how to unlock it so you can dominate and make your dreams a reality. No excuses, just dominate.